Hello, in this video we'll be discussing examination of the knee. Again, it's important to undertake a full history of the patient's normal health and also of their social life and impact that any knee injury may have on them. Someone who is more elderly and has a long-term problem with their knee, as in a degenerative problem, will obviously have different issues than a younger person who has a knee injury as a result of maybe a sporting injury. It's important to understand the difference and the interference that these problems are causing to patients' life, both in their social life and work life, or as part of a sporting injury. If someone has an injury due to sport, it's very important to understand the level of sport they play at and what their expectations are. We'll now move on to examining the knee. Examination of the knee starts with the patient being fully exposed so that we can look at the alignment of the limbs, particularly looking for any signs of varus deformity with the knee being bent inwards, or valgus deformity with it being bent out, or particularly of the patella squinting one way or the other. We're also looking for scars, and we can see our subject here has quite a large scar over his left knee from a previous injury. We need to look from the side. If you could turn towards me, please. Again, looking for alignment, looking for more scars, looking to make sure there's no increased recurvatum with the knee going backwards, and to check for the alignment, and also from the back. If you could turn to the wall, please, which is the only time during examination when we get to look at the popliteal fossa to ensure there's no sign of any masses or scars in that. If you just turn around and face the front again, please. Once we've done that, we'll need to walk our patient and look at the gait. If you'd just like to walk up and down forwards until I ask you to stop, please. Looking for the length, stride, cadence, looking for any abnormal positioning, such as a varus thrust or a valgus thrust, which would suggest instability. If you'd like to keep going, please. Also, it's possible to see inpointing of the patella or rotation and malalignment of the foot if it's not moving straight. I just ask you to walk from side to side. Looking from the side, we're looking to make sure the knee doesn't hyperextend whilst walking, and also to ensure that the knee is fully straight. Okay, thank you. If you'd just like to come back. Again, we would check the footwear for signs of abnormal wear, and also check for any walking aids that the patient might wear. In particularly relevant to this would be any calipers, AFOs, ankle foot orthosis, or similar. We'll now move on to examination on the couch. Having examined our patient standing up, we'll now examine them lying down, ensuring the patient's comfortable and there's no hip replacement above the knee that we're examining. I'd like to come to the bottom of the bed and check again for any signs of scarring, which is obviously it's sometimes more apparent here because of the change in lighting. Also, we check the neurovascular status again to ensure that the patient is feeling the same and normal on both sides, and check the posterior tibial and the dorsalis pedis pulse. Again, good thing to do at this point is to hyperextend or try and hyperextend both knees, as this gives a good indication of whether there's any asymmetry between the two. Just relax for me, please. Can you lift this your leg up straight for me, please? We're checking the extensor mechanism to ensure that this is fully intact before we move on with the examination. And the first thing to do really from the point of view of feeling is to look for an effusion. This is best seen in the medial gutter by stroking the fluid up and then stroking back down. You can see there's a slight bulge there. And again, with this, sometimes if there's not much fluid in there, actually decreasing the volume of the suprapatellar pouch by bringing the hand down is a good way of doing that. Just bend your knee up for me as far as you can. Okay. So check the full range of movement, of flexion and of extension, right the way back out for me, and any hyperextension that may occur. 5 degrees is normal. And then put the knee into a position where it's comfortable. And there needs to be a way of anchoring the foot, otherwise the foot will move and it'll be difficult to complete your examination. I tend to do this by sitting very gently on the patient's toes, having explained to them first what I'm going to do. I quite like doing this because it means that I can look at the patient's face and see if they have any pain or tenderness as I'm examining it. feeling around the patella on both sides and then down the patella tendon onto the tibial tubercle and then onto the joint lines both sides, both the lateral joint line first, feeling all the way around the back of the joint, up onto the lateral femoral condyle, and then onto the medial femoral condyle and around the medial joint line, going right the way back into the posterior aspect as far as possible, and then back round and down onto the tibia. It's also important to feel origin of the medial collateral ligament and the ligament in its length down to its insertion, and the origin and insertion of the lateral collateral ligament, as tenderness of these can be confused with tenderness of the joint line. To check for posterior cruciate damage, one needs to check for a posterior sag sign by placing the heels together and ensuring that tibial tubercles are in a straight line. If it's fallen back, if one side has fallen back, it would suggest a PCL injury. The other way of testing for that, again from this position, is to feel the tibial tubercles, so the tibial spine and the joint line. Place your thumbs on this, on the IPJ, and then bend back until you feel the femoral condyles and push back. There shouldn't be any movement there. It's good to also just gently pull forward at this point to ensure that we're not missing a PCL injury that's sagged back. Just relax as much as you can. Testing the anterior cruciate ligament. The best way of doing this is with Lachman's test, by flexing the knee to approximately 20 degrees, getting a good hold of the tibia and bring it forward. There should be a very firm end point to this. If it's a soggy end point, it suggests that there's some damage to the ACL. If you have a patient with large legs or if you have small hands yourself, a good thing to do is to relax your knee under the patient. Just relax as much as you can for me. And you can do the same by stabilising the femur and then using the other hand to pull up. Once we check the anterior and posterior cruciate ligaments, we then need to check the collateral ligaments by stabilising the foot and applying varus and valgus strain in both full extension. This is pulling in with the elbow, pushing with the hand to test the medial collateral ligament, and the opposite way around for the lateral collateral ligament, and in 20 to 25 degrees of extension, as this unlocks the ACL and the PCL. Okay, and this is stable. Could I ask you to sit up with your knees hanging off the edge of the couch facing that way? We now want to examine the patellofemoral joint, and the best way of doing this is the patient sitting with the legs over the edge of the couch and asking the patient to extend their knee slowly. If you can just do that for me, please. Bring it up. We're checking for the alignment of the patella, ensuring that it moves up, and just pop it back down for me, in a straight line, and then doesn't come across with a J-tracking sign, which would suggest wasting of the vastus medialis oblique. The other thing to be done at this time is to palpate the patella. If you can do it again, please. To check for crepitus. Pop it back down, thank you. And for the sake of completeness, we should examine the joint above the hip and the foot and ankle below to ensure we're not missing pathology that's coming from either of those places.